So I'm still going to try and share this my window only. I want to see the way it looks like. So you guys will tell me the way it looks like. Maybe that will be later. I want to know the differences between sharing the entire screen and window. Okay, so today we'll continue with the mediastinal pathology. So the mediastinum is just like the space in between the lungs, and there are some organs or structures that occupy that space. It includes the heart, the thymus, the lymph node, the esophagus, and the aorta. So the way I will classify it for us that will make it easy is just to picture it that anteriorly you have the thymus, you have the lymph nodes. Those are the basic two things that you have in the anterior mediastinal compartment: the thymus and some lymph nodes. Then the middle, you have the heart. The heart, of course, that one is very visible from X-ray. So if you are looking at an anterior posterior X-ray now, the heart is sitting in the middle. So the heart occupies the middle um, compartment. Of course, the great vessels emerge from the heart. So the great vessels, the heart, the great vessels, the heart, then the trachea as it bifurcates. The trachea, then posteriorly is just the spine, spinal cord, spinal cord. So I think it should be easy. Anteriorly, the thymus, lymph node. In the middle, the heart, the great vessels that emerge from the heart, the trachea, the esophagus, and some lymph nodes too. Posteriorly is just the spine. It's just the spine. So sorry guys, let me try and see if I can get an X-ray so that we can appreciate it better. Let's see if we can get an X-ray online. Mm, lateral X-ray. That's what I should have typed. Lateral X-ray. Mm. Well, I'm not really getting anyone that is very. That's the problem. That's very clean. All these ones are looking opaque. But you know, ah, oh, don't worry, guys. I'll try and find one and I'll send it to the page. I'll try and send it to the page. So, but can we see this one? Can we see this one that I'm projecting? Can we see this one I'm projecting? Hello, guys.
Yes.
All right. So the trachea will be somewhere up here, up. Mm, sorry, I said trachea. The thymus is just centrally up. Mm. Then lymph nodes too will be there. Then we have the trachea. We can see the trachea already in the middle compartment. The heart too will be in the middle compartment. We can see the aortic arch that are being labeled. So all those things are in the middle. The aortic arch, the ventricle, which is the heart, the trachea, the esophagus too will be somewhere there. Then posteriorly, mm, we can see the spine posteriorly. So that's that about the mediastinum. It's not hard. The posterior one, the mediastinal posterior compartment is occupied by the spine, the middle by the heart, the great vessels, the esophagus, the trachea, anteriorly by the thymus. Okay, so this has some clinical relevance because we can explain the location of masses that we find within the mediastinum. So we can find masses within the mediastinum which can include lymphoma, lung cancer, abscess. These three ones can be found in any compartment. We have lymph node everywhere. So lymphoma can develop from any of the compartments. Can have a lung cancer that spreads anywhere. The mediastinum is just in between the lungs. So a lung cancer can spread to any of the compartment, and also an abscess can develop and spread towards any part of the compartment. But there are some specific masses that you see in each of the compartment that we have listed. So the anterior compartment, we've said it that the two major things that you see there is the thymus and the lymph node. So from there, someone can develop a lymphoma. So they use the acronym T's to represent that. So the four T's. So the first T is terrible lymphoma. So you guys know that lymph nodes are there, so you can have a lymphoma. Then the thymus is there. A thymoma can develop from there. And thymoma is associated with which condition? Do you guys remember? Once you see a thymoma, what condition are you thinking of?
Myasthenia gravis.
Myasthenia gravis. Myasthenia gravis. Once you see someone with small cell cancer, what neurologic abnormalities is possible in that person?
Lambert-Eaton,
Lambert.
cerebral degeneration,
Mhm. There are so many of them.
yeah, ataxia,
Yeah.
deduction.
So the last two, teratoma and the thyroid gland. Teratoma and the thyroid gland. Now, teratoma ideally occurs, there are germ cells tumor that should develop within the gonads. But we've mentioned that we can have extra gonadal teratomas. And I listed some of those places that they can go to. We talked about the pineal gland, we talked about the retroperitoneum, we talked about the anterior mediastinum that day when we were doing the reproductive lecture. So the anterior mediastinum is actually the commonest extragonadal site of spread of or development of a teratoma. So you can have the germ cells migrating to that area and they will develop teratoma. Then lastly, thyroid. So what this thyroid mass that we are talking about is actually a substernal or a retrosternal goiter. That is enlargement of the thyroid gland that has descended into the chest wall or chest cavity through the thoracic inlet. So when you have 50% of the thyroid mass occupying the chest cavity, moving beyond the thoracic inlet into the chest, you call that a substernal goiter. That can cause problems with breathing because already impinging, within the chest cavity, so it can obstruct the airway because of that. So, a substernal goiter can be a mass within the anterior compartment, anterior mediastinal compartment, a thymic neoplasm, a teratoma, and the lymphoma. Then the middle, we've talked about what you can find within the middle compartment. We talked about, okay, so now, you guys, this is the latest book. They've deleted things. They've deleted things. If you are using 2022, beautifully, you are going to see esophageal carcinoma. That makes a lot of sense. Esophagus occupies the middle compartment. So someone that has an esophageal carcinoma can have a mass within the middle mediastinum. Someone that has metastasis, so metastasis from anywhere can also occupy the middle mediastinum, just like we talked about. Someone that has a bronchogenic cyst. We've said it during the course of our lecture that bronchogenic cysts are just abnormal dilatation of the respiratory diverticulum. So you can have abnormal budding within the trachea or the bronchiole. The bronchi or the trachea can have abnormal dilatation within them, and that dilatation contains the normal epithelial lining of the trachea, the bronchi. It contains cartilage, and it can accumulate fluid. When it accumulates fluid, they become cysts, and that cyst can compress on the airways itself. It can be a needle for recurrent respiratory tract infection. So although some of them can resolve on their own, they might just drain and resolve. But in some situations, they might not drain, and you tend to have compressive symptoms from there and recurrent respiratory tract infection developing. So because of the fact that they can develop on the trachea, and trachea is also one of those components within the middle mediastinum. So bronchogenesis is it's one of those masses that you can find within the mediastinum. The posterior compartment, we've said it. So, okay, they moved esophageal cancer to posterior. Okay. Oh, I get it now. So, it may present as a mass or spread to or can occupy the middle mediastinum. So, ideally, the posterior, the esophagus is actually occupying the middle, you know. So, but it's because of the fact that the esophagus is very proximal to the spine. So it can also spread to the posterior mediastinum. So I think that's why they are shifting it to the posterior uh, mediastinum now. Okay, so it can fill in between the middle and the posterior mediastinum, and of course the easy ones for posterior mediastinal masses, multiple myeloma. Multiple myeloma is you guys know is a hematology condition, and you can have those malignant plasma cells releasing interleukins like interleukin 1, tumor necrotic factor. You guys remember interleukin 6 in hematology then, and Those interleukin, particularly interleukin 1, is also known as, who knows other name for interleukin 1? Anybody? So another name for interleukin 1 is osteoclast activating factor. So it can activate the osteoclast and cause bone resorption. So it can affect the spine, and you can have bone pain in the spine, vertebral, bone back pain because of that, and vertebral collapse. Then neurogenic tumor, for example, a neurofibroma that develops from the peripheral nerves emerging from the spinal cord. So you can have a mass from there that compresses on the spinal cord, existing as a mediastinal mass because it's from the spinal cord, and the spinal cord occupies the posterior compartment. So that's that about the masses. So mediastinitis from the name just means inflammation of the mediastinal structures. The the commonest cause of mediastinitis, which is like inflammation of the mediastinum, is secondary to cardiothoracic procedure. So someone that has done a surgery, a chest surgery, especially within 2 weeks, they can develop, mediastinitis. The other causes include esophageal perforation. So there are so many things that can cause perforation of the esophagus. Esophagus is one of the components of the middle mediastinum that I've talked about. It can rupture or perforate, and there will be release of the esophageal content into the mediastinum, which can cause irritation and bring about inflammation. So it can be secondary to maybe a malignancy. It can be secondary to maybe injection of caustic soda, or trauma, or even excessive retching or vomiting like Boyve syndrome. So you can have esophageal perforation from there. Then it can also be from a spread from contiguous structures. And the two major contiguous structures that we are talking about is actually the pharynx, like maybe from a pharyngitis or from the teeth. So because the cavity of the teeth or the mouth continues has a continuity, so it has a continuity with the mediastinum through the deep spaces of the neck. So both the pharynx and the um the oral cavity, they have continuity with the mediastinum through the deep spaces of the neck as well as the facial planes. So that means that infection can track along those facial planes and descend down into the mediastinum. So someone that has a dental abscess, or someone that has a pharyngeal infection, they can develop mediastinitis. You can also have hematologic or lymphatic dissemination of infection to the mediastinum. But the commonest one that you guys should pay attention to is cardiothoracic procedures, esophageal perforation, and spread from the pharynx or the teeth. Okay, so that is simply acute mediastinitis. So, chronic mediastinitis is now talking about the inflammation that is now long standing. At the end of the day, there's going to be an attempt at repair with formation of scar tissue and fibrosis. So the commonest cause of that is histoplasma capsulatum infection. This is a fungi that can, the fungus that can cause chronic mediastinitis. Tuberculosis can also be a cause. Radiation exposure can be a cause. But you guys should just have it in the back of your mind that histoplasma capsulatum is the commonest cause for chronic mediastinitis. So what are the features of someone that has mediastinitis? They present with fever because of the inflammation, the itis. That's fever, inflammation. They have tachycardia, they have chest pain. And because of the inflammation, the infection, part, you can develop leukocytosis. So for people that have done surgery, you are going to notice drainage within that sternal wound. So it's going to be continually draining. Yeah. So you guys should always remember the chest pain, the fever, the tachycardia. Then in case of infection, leukocytosis, and the wound drain for people that have done surgery. Pneumomediastinum. So pneumomediastinum is very important. You guys must know it. Pneumomediastinum just means presence of gas within the mediastinum. That's what it means. It can be spontaneous or it can be secondary to something. If it's spontaneous, it's actually due to rupture of a bleb. So a bleb is just like an air-filled cavity that is located between the lung parenchyma itself and the visceral pleura. So you guys know that if you look at the lung is invested by the visceral pleura. Then next to the visceral pleura is the parietal membrane. So between the parietal pleura and the visceral pleura, that's where you have the pleural cavity. So a bleb is now like air collection that is forming like a cavity in between the lung itself and the visceral pleura. it's very common in people that are tall. So all these people with Marfan disease that they are just abnormally tall, or just very tall people, because when the person is tall, there is also an ascent of the lung in terms of growth. So there's an increased upward growth of the lung. So that growth of the lung is actually with formation of those blebs. So they will be there and they can rupture. So once they rupture, you have pneumothorax, you can have pneumomediastinum. So you can have the air finding its way into the pleural cavity or finding its way into the mediastinum. So if it goes far out of the cavity, it can enter the mediastinum and the person can develop pneumomediastinum. But in some cases, it can be secondary to trauma. So if someone has a direct stab injury to the lungs, you puncture the lungs, you puncture the alveoli, there's rupture of the alveoli, you have air tracking from the peribronchial sheath and the perivascular sheath. So these are just like tissues that are surrounding the bronchi and the vessels within the alveoli. So the hair can follow those sheaths and move into the mediastinum. Or iatrogenic, maybe during surgery or you are trying to pass a chest tube or something, you puncture the lung and you have the pneumomediastinum. Or someone that is having Boehm syndrome. So if there is rupture of the esophagus from this Boehm syndrome, there's air escaping into the mediastinum from the esophagus. So air can leak out from the esophagus into the mediastinum and can cause pneumomediastinum. So that's one of those things that you want to look out for. Pneumomediastinum. Is it that this guy had esophageal perforation or rupture or something, or there's a trauma, to the lungs, or it's spontaneous from, rupture of a pulmonary bleb. So, what are the salient features? You guys cannot miss this. The number one thing, air is accumulating within that mediastinum. It causes a central chest pain. They have a central chest pain. That's number one. You know, because of that, there is also dyspnea. So the hair is there, you know, um, not allowing the normal, expiratory movement of the lungs and all those things. It can cause dyspnea. Then, most importantly, it causes what we call um, subcutaneous emphysema. So, in subcutaneous emphysema, what is happening is um, the air is finding its way into the mediastinum, then it's tracking along the muscle, through the muscle into the superficial fascia. So, it can, travel along the superficial fascia, particularly that of the neck, the face, and the head. So you just see that the person becomes edematous. So there's edema of the face, the head, the neck. That is subcutaneous emphysema here within the subcutaneous tissue or the superficial fascia. The person also develops voice change, and it's just like the person has inhaled helium. So you notice that like voice of change in the voice because of the too much air within that chest. It also affects the intensity or the quality, of the voice. So it changes the voice. It makes it like tiny, you know. Then, lastly, Hammond sign. Hammond sign just means you hearing like crepe, you know, like a should I call it like a squeezing sound now? When you auscultate over the precordium, so you hear those crepe, you know, because of the air that is just circulating over the mediastinum. And you know that within the mediastinum, the heart is there. So you have enough air circulating over the heart. So if you listen, you are going to hear those crepitations. So once they tell us that you're able to hear crepitation, not in the lungs, but in the heart, on the precordium, that is Hammond sign. Diagnostic of neuromediastinum. We see the person just having sudden swelling of the head, the neck, that is subcutaneous emphysema. That is not angioedema. Voice change, dyspnea, and chest pain. Neuromediastinum. We should watch out for neuromediastinum. Okay. So we talk about the flow volume loops, for the restrictive and the obstructive pattern. The flow volume loops for the obstructive and the restrictive pattern, and as well as that of the normal lungs. Okay. So when we talk about obstructive disease, that just means that there's an obstruction somewhere in the airway. You know, it might not be a physical obstruction, but in obstructive lung disease, there is a more like a resistance during expiration. You guys have to know that there's a resistance usually during the expiratory phase for obstructive lung disease. But in restrictive lung disease, there's no resistance anywhere. There's no obstruction. The only problem is that the lung has shrunken and has become like maybe fibrotic, and the compliance is being reduced. So that means that the volume of air that it can accommodate is very small. So it's just like somebody squeezing a paper and filling it with water. Let's say that paper cannot stretch. No, don't let me use paper. What example can I use now? If something becomes fibrotic and you try to fill it, the volume that it will take will be different from the volume when it is normal sized. So that is that about the restrictive. Because of that small decrease in the compartment, there's a reduced volume. But in obstruction, they can take in air, but getting it out is a problem because of that obstruction, which can come from myriads of cases. So let us start with the restrictive lung disease. Because of the fact that in restrictive disease, during inspiration, you are not taking in enough air. It's not due to obstruction, but it has little capacity, little compliance to stretch in response to that increased volume. It cannot stretch, so they will just take small volume. Instead of them taking like 6 liters, they will just take like 4. That's the capacity. They stop. So that means that all the lung volume will decrease, all the lung volume, and particularly residual volume, because it is what you breathe in that you can take out. So if you breathe in 4 liters and you try to breathe out and you take out 3 liters, it will remain 1 liter. So someone that breathes in 6 liters, okay, let's start again. Someone that has a restrictive disease breathes in 4 liters and breathes out 3 liters, it will remain 1 liter as residual volume. Someone that has normal lung has 6 liters. The person brings out 3 liters. It will remain 3 liters as residual volume, right? So that means that in someone that has a restrictive disease, the residual volume reduces. And if residual volume can reduce, functional residual capacity too will reduce, because functional residual capacity is also the amount of air that remains within the lung at the end of the normal tidal expiration. And you even incorporate the residual volume part of the formula for functional residual capacity. Your functional residual capacity is the expiratory reserve volume plus RV. So if RV reduce, FRC too will reduce. And of course, the total lung capacity is reduced. That's even the starting problem. Total lung capacity reduces in restrictive disease. If they want to breathe out, we are talking about the FEV1 and the FVC now. So FEV1 means the first expiratory volume in 1 second. That is the amount of air that you can breathe out of the lungs in 1 second forcefully into a spirometer. The first vital capacity the FVC is talking about, the amount of volume of air that you can breathe out after taking a maximal inspiratory breath. So you take a maximal inspiratory breath, then you breathe out forcefully. So that air that you can get out, is the first vital capacity. Now, because of the fact that there is no resistance, both FEV1 and FVC are going to reduce proportionally. They reduce proportionally. So they reduce by the same amount. So at the end of the day, the FEV1 over FVC ratio might be normal. It might be normal, or it can even be increased. Because the reason why it can be increased is that people with restrictive lung disease, if you guys would remember the concept of elastic recoil, the elastic recoil in people with restrictive lung disease is preserved, because elastic recoil, have told us to look at it as something that's bringing the lung inwards so that they can bring the air outwards. It is not damaged in restrictive lung disease. They still have it intact, and that actually helps us to accelerate expiration to bring out the air. So that means that they can even quickly bring out air within 1 second. So it's possible that the FEV1 will still be slightly increased than the FVC, because that elastic recoil will quickly help them, bring the air out within 1 second. So you have little to bring out, later, which will constitute your FVC. So it can be possible that you can have an increased FEV1 over FVC. You guys should pay attention to that. Don't say that FEV1 over FVC ratio is more than normal. This person is normal. It can be a restrictive lung disease pattern. And of course, it's also normal in people with restrictive lung disease, because the decrease in the FEV1 and decrease in the FVC normally is equal. So if you have an equal decrease, that means that the ratio will be normal. Yeah. So what is this ratio that we're even talking about? Once you have that ratio less than 70%, normally it should be more than 70%. Once you have that ratio less than 70%, we are looking at an obstructive pattern. Once you see it more than 70% or is even far increased like 80, 90, you are looking at restrictive. Yeah. So let's go to obstructive pattern. Obstructive pattern, instead of you having decrease, you have increase in the lung volume and capacity. Why? Because in obstructive pattern, majority of them they have trapping of air within the air spaces at the end of expiration, because we've said it that some of them have problem with getting air out of the lungs during expiration. So there's air trapping. There's what we call air trapping. That air trapping is what will help us to explain why people with obstructive lung disease can have pulsus paradoxicus. We are going to explain. We are going to get there. So they have air trapping because they cannot get the air out within expiration, so it accumulates. So that means that if I take a deep breath and the person has a COPD and the person takes a deep breath, the person wants to expire and bring those air out, there's a resistance. So that means that the amount of air that you can bring out is limited. So that means that the air that is left within lungs increases. So it makes sense for us to say that the residual volume increases in obstructive lung disease. And if there's an increase in the residual volume, there will be an increase in functional residual capacity. And if there's an increase in functional residual capacity, it will affect the entire lung. Total lung capacity also increases. Total lung capacity also increases. But now, let's look at the spirometry pattern. You should tell this person to take a spirometer to try and do the pulmonary function test. So you notice that um, if they, at the 4 seconds of expiration, that's the first expiratory volume, it's reduced because there's a resistance at expiration. So they can hardly bring those air out. So the amount of air that they will bring out is reduced. And FEV1 is drastically reduced compared to FVC in people with obstructive lung disease. So because of that decrease in FEV1 compared to FVC, the ratio will be less than 70%. So you guys have to know that in obstructive disease, the FEV1 decreases more than FVC. It decreases more than FVC. So at the end of the day, the ratio is less than 70%. But in restrictive pattern, it's either equal or it is increased. Now, we also have to pay attention to the individual values. If you don't want to classify them as a ratio, you are not taking the ratio. So if you take them independently, that is the value of the FEV1 that you get. Normally, it should be more than 80% predicted. In individuals with obstructive lung disease, it is less than 80%. And it is very, very reduced. In people with obstructive lung disease, the FVC2 is less than 80%. So 80% is the cutoff value for the individual volumes, like FEV1 or FVC. 80% is the cutoff value. But for the ratio, it is 70%. Please, guys, don't mix it up. Don't mix it up. So that you will not go and pick FEV1 over FVC ratio of less than 80. No, it is not 80, but 70. But in the individual value, FEV1, they can give you FEV1 only. It should be more than 80, but in individual with obstructive and restrictive is less than 80 in both of them. FVC2 is less than 80 in both of them. But in obstructive, FEV1 is drastically reduced more than FVC. That is why the ratio is less than 70% at the end of the day. Okay. So let us look at the pattern that we get. So they had this flow volume loop pattern a lot. We have to understand the way it works. So for the first one, this is a normal. Like you can see, we are starting from here. So this value here should be around 1.2 liter because that is talking about the residual volume. You guys can see the difference between 0 and that point. So that is the amount of volume of air that is present within the lungs at the end of the normal first expiration. That's residual volume, right? So If we take a deep breath, it will increase, to if you take a deep maximal breath, it increases to, the total lung capacity, which is 6 liters. So that means that from 0 to this 1.2 that is here is actually residual volume. So that means that, and we know that total lung capacity is the sum of the RV plus the vital capacity. So that means that the distance between this 1.2 to 6 will be our vital capacity. That is very easy. And we can see that that curve is actually showing two phases. The upper one is expiration. The lower one is inspiration. So from 1.2, you inspire, you increase the lung, you increase the volume to 6 following inspiration. Then at expiration, you expire, you reduce the flow. So okay, let me just point out the fact that the curve on the y-axis is actually talking about the flow rate in liter per second. The curve on the x-axis is talking about the volume. So let's start again. At 1.2, that's the residual volume. You take a deep maximal inspiratory breath. You increase the lung volume to total lung capacity 6. Then from that 6, you start expiring again. So the person expires, brings out the hair, and of course you can see that the pressure is increasing as the person is expiring, then drops again, till the person gets to um the residual volume. This has to be an active process. You have to be breathing out maximally. So this person is not taking a tidal respiration. He's breathing in maximally, and the person is breathing out maximally. So you guys remember that vital capacity is talking about breathing in maximally initially, then breathing out maximally. The total amount of air that you get out, after you breathing in maximally is your vital capacity. So that is why vital capacity is actually between that 1.2 to 6, which is about 4.8 liters. Do you guys get this curve? Do you guys understand what I've said? Hello?
I would say partially to me. I would say partially. Like, if
So,
I sit down with it again, I think I should be able to get a full grasp of it.
okay. Dr. Adiola, did you get it?
Uh,
Hello?
hello, can you hear me?
Yes. What did you say?
Yeah, I did. Don't make sense. Yes, I
Okay.
did.
Dr. Abisola, what about you?
Mhm.
Dr. Abisola?
Hmm.
I said they did. So why are you saying, oh?
No, stop,
Wrong.
I didn't hear you.
Can you hear me? Okay, let me tell them. A bit.
A bit. Dr. Lushola, what about you?
Okay.
Yeah, I got it.
So let me just take it one more time. So we are looking at the starting. If someone has maximally exhaled, the remaining volume of air in the lungs is what? After a maximal expiration, what is the remaining volume of air in the lung?
Residual volume?
Residual volume.
That is residual volume, which is about 1.2.
Yeah.
Which is about 1.2. That is why you are seeing this pink dot starting very close to 2. This is around 1.2. Now, the next thing for the person to do is to get in here into that lung. You will inspire. Now, for you to get it to total lung capacity, you have to inspire maximally. That's the only thing you can do. So you inspire maximally. So you take it from this 1.2 to 6. Then the next thing is to what? To exhale
To expire, yeah.
maximally. So it goes back from this 6 to our residual volume, because you can't get the residual volume out of the lung. It will be there. We take it back to residual volume, which will be 1.2. And you guys remember definition of vital capacity. It is the volume of air that can be brought out after a maximal expiration. Although before that maximal expiration, you will have taken a deep maximal inspiratory breath. This is exactly what this person is doing. If you notice, the change in all the parameters is just 4.8 liters from 1.2 to 6, then 6 to 1.2. It's 4.8 that the person is changing. So that's why they are
Yeah.
tracing that arrow from this 1.2 to 6 to be your vital capacity. If you add it to the one that's just beside it, which is 0 to 1.2, that is our residual volume. The total of them is our total lung capacity. That is it. Now let's now look at changes that happen in obstructive disease. What are the changes that happen? Now we've said it. Someone that has obstructive disease, the person has air trapping. So that means that the residual volume will what? What will happen to the residual volume?
It will increase.
It will increase. Now look at the starting. Look at the starting of this curve. Look at the starting. You can where is it? Where is this curve starting from? Dr. Oluwatobi.
It's
Where's the curve?
starting from like 2.8, 3 point something.
Yes. So it's starting from 3 point something. It's starting from
Yeah.
3 point something. Hmm? It's starting from, this pink one is actually talking about the normal. This pink curve is talking
Yeah.
about the normal. But this green one is talking about the obstructive lung disease. You can see that it's starting from like 3.8. You have added 2
Yes.
or 2 point something to it, because of the trapping. So that means that your residual volume has been increased to 3.8. Now, you now take another, deep inspiratory breath again. So that if you add 4.8 to that, the normal vital capacity, is going to get it to about 8 point something. Then, you breathe out again. But you guys notice
Yeah.
that when you are breathing out, you notice that this curve, there's actually more like a slope. It's not as straight. That means that the person is
Yeah.
actually
It's not as straight and it's not even.
as
Yeah.
tall.
It's not as straight and then it's
Yeah,
not the height. Yes.
it's
It's
not the
not as
height. So
tall.
I'm going to come to the height. The reason why it's not the height is because of
Okay.
the
The
reduced volume.
slope.
Exactly. It's because of the reduced volume
Okay.
in both of them. You notice that both in restrictive and obstructive, the height reduces. So because of the
Yeah.
fact that
Yeah.
there's an obstruction in this obstructive lung disease, so that resistance is actually the one that is making it not flow at the normal flow rate
It's
that it
not
should be.
should.
Exactly. Then you can see that there's more like a slope. So it's not as straight, it's not as steep as the usual one because of the resistance that they encounter in expiration. And you guys notice that that slope is actually happening at the expiratory phase because we've talked about the expiratory phase being the one on top. Expiration is the one happening on top. So we can see actually I thought this phases was actually labeled in the old one. They did not label it here. So they labeled it as expiration and inspiration. Expiration is one on top, you know. So at expiration, that's when the obstructive people they encounter their problem. So that is why you're having that height not being high and also that slanting at the expiratory phase. Now, if you go to the restrictive pattern will appear similar as normal. It will just reduce in the height and it will reduce in the volume. So because of the fact that you're restrictive, you cannot even bring too much air into the lungs. So that means that your residual volume will drop. So that means that the person cannot start at 1.2. The person is starting very close to 0, just like we are seeing here. So it shifts the loop to the right, while the obstructive shift the loop to the left. So that means that ideally, when you want to interpret all this graph, what you just look out for is that, okay, where is my curve shifting to? Is it shifting to the left, which represents higher volume, making me know that this is likely to be an obstructive pattern, or is going to the right, representing lower volume, which is what I expect for a restrictive pattern. Then to be further sure of which curve you are going to pick, for obstructive, you are going to pick a curve. Of course, both of them will have reduced flow rate in both of them, with a slight curve, at the expiratory phase for the obstructive. For the restrictive, it is the same pattern. It's just that it shifts to the right and the peak is reduced both at inspiration and expiration because of the reduced volume that you are taking in. So you guys can see this guy here starting at uh around maybe like 0.8 or something. The person taking in the air, getting it to 4, the person cannot get it to the maximum lung capacity. The maximum lung capacity in this person is likely to be around 4, right? So this person total lung capacity is 4. So the residual, the vital capacity of this person will be like 0.8 minus 4. That's still lower than normal. Then you can see that the peak is also reducing both in inspiration and expiration. So that is it.
But Wally,
Yes, Dr. Luake.
the this thing, it is starting from 0 point something
Mm-hmm.
because it is just the residual capacity in these people is also low, abi?
Yes, yes, yes.
Okay, so and then they're even bringing little air in also.
Exactly.
So
Exactly.
okay,
So the flow
thank you.
rate now reduces. Flow rate also reduces because they are bringing little air in. So the flow rate reduces. So
So, but there's no resistance when the air is coming out. That's why
exactly,
this one is not slow.
it's not slow.
It does not have that slope. Okay.
Exactly. There's no resistance anywhere. It's
Okay.
just that it doesn't accommodate much volume. That's it.
Mark Barrow.
It
So the
doesn't
primary
accommodate.
problem in restrictive is the air coming in is low,
Mhm.
and that's why you are expiring the same volume.
You
Your
get
first. Okay,
that
thanks.
is it. That is it. That is it. Hmm. So you have to pay attention to the shifting too. I know you guys will be able to figure that out now. Okay. So let us now start taking those guys into consideration one by one. So obstructive lung disease, we talked about it. Obstruction of airflow. So there's a drop in the FEV1 more than FVC. That's very important. So both of them are less than 80, but the drop in the FEV1 is more than the FVC. The ratio is also reduced. It's not normal, it's not increased, but reduced, less than 70. There's air trapping within the lungs, causing the hyper inflation. So there's air trapping because the residual volume increases. Residual volume increases. And if residual volume increases, what will happen to the functional residual capacity, which is the sum of residual volume and expiratory reserve volume? Functional residual capacity also increases. And of course, overall lung capacity also increases. Very important. All this increment is what is responsible for why there is an increase in the thoracic volume and thoracic capacity. So the chest increases in size. There's hyperinflation. That's why they can have that barrel chest. So, and they have,
Okay.
yeah, so they have, and this is due to premature airway closure at a very high volume. So the way I want us to picture this is that, okay, if someone has an obstructive lung disease, and particularly let's say that this guy has a COPD, let's say emphysema. Emphysema, the problem in emphysema is there is um uh a damage to the elastic fiber surrounding the alveoli. So that means that the elastic recoil cannot be achieved. So that means that they can actually take in air. When they are taking in air, the alveoli will expand. But when it's time to do elastic recoil and take the air out, that's where they will now not be able to do anything. So the air they keep taking in during inspiration keeps accumulating within the alveoli, causing air trapping and accumulation of air within the intrathoracic compartment. So that elastic recoil should normally help with opening the airways. How? Now, if you guys remember that when you have elastic recoil, you are bringing the alveoli together so that they can force air upwards into the atmosphere. Now, the proximal airways are just above the alveoli. They will open when you have that elastic recoil because it will squeeze on the alveoli when there's a recoil so that I can push the air up. That's the mechanism. But if you don't have that elastic recoil, there's nothing to squeeze on the alveoli to push the air up and open the proximal airways. So that is why they have airway collapse. People with obstructive lung disease, there's high tendency of having airway collapse because that recoil is not there. It's not there. So the commonest cause of, the common causes rather of obstructive lung disease include COPD, like chronic bronchitis, emphysema, then asthma is also a cause, then bronchitis. We are going to take them one by one. So let's talk about the COPD. Um, they don't even okay. So chronic obstructive pulmonary disease actually is a representation for two terms: chronic bronchitis and emphysema. We call the chronic bronchitis the blue bloaters. You guys are familiar with that. They appear cyanotic. They are blue. The emphysematous type, we call them the pink puffers. They appear pink. They are not cyanotic. Now, the single most important risk factor for someone with COPD is smoking. There's no way they will paint that history and they will not talk about back years that the person has been smoking. So it can also be secondary to other pollutants, maybe here, smoke from burning fossil fuels or firewood and all those things, or allergic, allergic exposure. So they can all bring about COPD, but the commonest one is tobacco. Tobacco. So it can actually be a chronic bronchitis event or emphysema, and sometimes both of them can coexist in one patient, which is very, very bad. Which is very bad. So you can have exacerbation of those symptoms that they experience. We are going to talk about them, and usually that is usually secondary to infection. So if the person has developed, and some infections are very common to them, like the influenza, the pneumonia, the pneumococcal infection. That's why you tell people that have COPD to take pneumococcal vaccine. They must take it within 5 years. You know, take pneumococcal vaccination, then influenza vaccination, because those are the two common infections that constitute problem for them, which can exacerbate that um, disease condition that they exhibit. So let's talk about chronic bronchitis. Okay, so chronic bronchitis is a clinical diagnosis. How would they present? You can say someone has chronic bronchitis if someone has been having productive cough, that is, the person has been coughing chronically, chronic cough with sputum production. Very important. That's why they use the word productive. So there is cough with sputum for more than or equal to 3 months in a year. So that means that if someone has been coughing for a year, the person has to have coughed for more than 3 months in that year. It's not that the person will cough for like 2 months, he will stop. Cough for another 1 month, stop. Cough for another 2 weeks, stop. Then everything will now constitute 1 year. No, the person must be coughing consecutively for 3 months within a year, and it must happen like that for 2 consecutive years. That is when you can make diagnosis of chronic bronchitis. So the problem in chronic bronchitis majorly is that smoke is going to cause release of um, some inflammatory mediators, so which causes increased secretion of mucus within the goblet cells. So the goblet cells will increase in size. They will undergo hyperplasia. They will undergo hypertrophy, because the goblet cells are the cells that actually lines the wall of the airway. We talked about them. We talked about where you find the goblet cells. So we say, do you guys remember the code that we use for goblet cells? Do we even remember? Can we even remember? Yeah, we say that, okay, how you can know the level where you find the goblet cells. Do you guys remember? Nobody remembers. Okay, so I talked about goblet cells being seen together with cartilage. So cartilage and goblet cells, they go together. So at what level do we see cartilage?
Check out the bronchioles.
Exactly, the trachea and the bronchi, not bronchioles, the bronchi, the big one, and the cartilage and the trachea.
Yeah.
Those are the ones that contain. So those are the ones that also contain the goblet cells. So in response to that smoking, they secrete that um the goblet cells undergo hyperplasia. They are increased in size. They secrete a lot of mucus, and that mucus affect the ciliary muscle, the ciliary movement of the pseudostratified ciliated columnar epithelium. So these epithelial cells lining those airway, the tracheal and the bronchi, contain cilia. So that increased mucus production denotes those cilia, damages them, so that the mucociliary clearance of that airway is lost. So the mucus keep accumulating within the airway. So that mucus accumulate, they form mucus plug that causes obstruction. So that means that the person will experience dyspnea because of that obstruction. Accumulated mucus brings about the sound of crackles. So crackles is not only seen in pneumonia. Crackles is not only seen in heart failure. We can also hear crackles in chronic bronchitis. We can also hear crackles in someone that has pulmonary fibrosis. So crackles is not actually a specific um, finding. It can be seen in so many conditions. So the mucus that is accumulating too much within the airway is what is bringing about the crackles. And of course, from the bronchoconstriction and the airway narrowing that they experience, it can explain the wheezing, like someone that has asthma. The wheeze also, because of the obstruction. So they have dyspnea, they have wheezing, the crackles, and they are cyanotic. So the cyanosis here is actually due to the severe shunting that they experience. So that particular airway, will not be able to deliver oxygen to the pulmonary capillaries. So at the end of the day, you have um deoxygenated blood mixing with other oxygenated areas. Let's say that some other bronchioles that are still working that can ventilate. So those ones will ventilate get the oxygen content to the pulmonary capillary they are supplying to 100%. But the ones that are blocked, they cannot oxygenate their own. So those deoxygenated blood can mix with the other oxygenated blood, and it can reduce, the oxygen content, which can explain the hypoxemia that they experience. So that hypoxemia can bring about polycythemia, because hypoxemia can cause hypoxia. It will activate, the peritubular capillary cells of the kidneys, which will bring about production of erythropoietin that causes polycythemia. So one of the classic signs is cyanosis. Because of the shunting, they are cyanosed. That's why we call them the blue bloaters, and they can have polycythemia. So you can see their palms to be red because of increased hematocrit. So, and at the end of the day, because of the irritation from the smoking, it can lead to metaplasia of the pseudostratified ciliated columnar epithelium to the stratified squamous epithelium. You guys remember, smoking is one of the causes of squamous cell cancer. So is an irritant that can, cause a metaplastic change from the pseudostratified ciliated columnar epithelium to the stratified squamous epithelium. Now, we can see the mechanism, hypertrophy and aplasia of the mucus secreting glands in the bronchi. There's something we call the Reed index. So Reed index is just talking about the thickness of that mucus layer and the thickness of the entire wall of the airway. So if you measure the distance between the thickness of the mucus that you are seeing over the airway, it should be less than 50%. But in individuals with chronic bronchitis, it's more than 50%. That's what we should pay attention to. Reed index is a common pathologic parameter that they measure. All these pathology people, they measure it a lot. So Reed index, very important. More than 50%. The thickness of the mucus gland layer to the thickness of the wall in between the epithelium from inside to the cartilage from outside. That is it. So the cartilage surrounding the wall, to the epithelial lining in the inside, that's the entire wall. Then the gland layer, which is the mucus that you are just seeing, just measure that mucus only over the entire thickness of the wall. If it's more than 50, you are dealing with chronic bronchitis. Okay. Yeah, so emphysema. So that's that about chronic bronchitis.
No,
Emphysema.
but I saw the question on this bronchitis, and they were like, "What is responsible for the?" Oh God, I remember the time I've forgotten again. It was like, "What is responsible for?" Okay, if I remember, I'll ask you. It has to do with resistance, pulmonary airway, something,
Exactly. So
something.
what will you pick? So what are the potentials that you want to pick now?
So they picked something cardiac. They put I picked pulmonary arterial pressure. Sha. Like, what did I pick? I can't. I'll look for the
Is it
question
not
later
related
and
to
find it.
mucus plug, like mucus accumulating? Is not that?
No, it wasn't that. I will check and get
Okay.
back to you.
Okay. Let's just see.
But there is something about resistance.
Okay. Yeah, no wala, no wala. It could be maybe from the hypoxemia. So maybe there's,
But
hypoxia.
I remember now. I remember now. So they were like CO2 something something. What is driving? In them, CO2 is not what drives the.
The hyperventilation.
Yes. So they
Okay.
had the question around that.
Okay.
Yes.
So it's the hypoxemia. Okay. Let's see. So when you see it, we'll check it. Okay. So emphysema. Emphysema. The problem in emphysema is not mucus problem. The problem in emphysema is due to damage of the alveoli, the damage of the elastic fibers that are surrounding the alveoli. That's the problem in emphysema. So what is the problem that is causing that alveoli damage? It can be two basic things: alpha 1 antitrypsin deficiency or smoking. Alpha 1 antitrypsin deficiency or smoking. We used to have beautiful images in the old textbook. Okay, I think they are trying to make the volume of this book reduced. That is why they are removing images, they are removing stuff, so that it can be very compatible for students. I think that's the reason why they are doing it. So yeah, so um yeah, so Smoking is one of those things that can damage those elastic fibers. How? When someone smokes, there is increased production of protease enzymes because you have to recruit inflammatory cells from that smoke. So smoking generates free radicals. The inflammatory cells come around, the neutrophils particularly. Neutrophils release protease enzymes. So this protease enzyme includes neutrophil elastase. So those elastase goes to the alveoli capillary wall and they damage the elastin that is there. So when the elastin damages, that means that the elastic recoil of the alveoli is lost. So that means that you have increased air trapping. That's one. The second mechanism is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is normally an antiprotease enzyme that is produced from the liver. So if it's deficient, that means that there's nothing to counteract the neutrophil elastase that is being produced normally. So if the neutrophil elastase is not being counteracted, you have the elastase working unopposed to damage the elastic fibers, and it can render that alveoli useless. So what are the peculiarities of these guys? It has been observed that people that smoke, the damage usually occurs within the upper portion of the lung. It occurs within the upper portion of the lung, and it is centroacinal. What do we mean centroacinal? Now, acinus is just talking about the functional respiratory unit. The functional respiratory unit consists of the respiratory bronchioles and the alveoli. You guys remember, we said the respiratory apparatus begins with the respiratory bronchioles. So, if it damages only the respiratory bronchioles from up, it just damages the respiratory bronchiole from up centrally, that is a centroacinal. It's sparing the alveoli that are located distally. But someone that has one antitrypsin deficiency, it has been observed that one damages everything, both the respiratory bronchioles and the alveoli. So you can call that pan-acinal. Pan means entire. Pan-acinal damages both the respiratory bronchioles and the alveoli. And it typically affects the lower portion of the lungs, the lower lobes. Unlike smoking that occurs at the upper lobes, alpha-1 antitrypsin occurs at the lower lobes, and it is pan-acinal. That means damaging both the respiratory bronchioles and the alveoli. While smoking damages only the respiratory bronchioles and is affecting the upper lobes of the lung. Okay. Now what happens? When there's alveolar wall destruction, the elastic recoil is lost. That means that the compliance of the lung is very high. They are very compliant doing inspiration. They can take a lot of air inside. The recoil is lost. They cannot bring out air during expiration. And of course, the damage spreads and involves the capillary membrane itself. When the capillary membrane is damaged, the capillary membrane is one of the parameters or one of the components of the respiratory membrane that allows for diffusion of gases between the alveoli and the pulmonary capillaries. So that means that in someone that has emphysema, the DLCO, which is the diffusion constant for carbon monoxide, so reduces. So that means that this DLCO is actually talking about the amount of carbon monoxide that you can take into the pulmonary capillaries across the respiratory membrane. Anybody that has problem with the respiratory membrane, because we've said it that carbon monoxide is diffusion limited. You guys remember, carbon monoxide is diffusion limited. So if there's anything affecting that respiratory membrane, it will affect the uptake of carbon monoxide from the alveoli into the lungs. So that means that the diffusion capacity for carbon monoxide reduces. The diffusion capacity for carbon monoxide reduces in form of the DLCO because of that damage to the alveolar membrane in someone that has emphysema. You guys notice that this is not the situation in chronic bronchitis. Chronic bronchitis is quite different from emphysema. You will not typically see that barrel chest with chronic bronchitis because there's an obstruction. Yeah, it might be there, but it's more prominent with emphysema because in emphysema, it's not as if you have obstruction like that. It's just that you have increased, compliance of the alveoli because they cannot recoil. So they have higher space to take in air during inspiration. So at the end of the day, the lung cavities are going to be increased in size, which is responsible for the barrel, chest that they experience. The barrel chest, I didn't know that they will have removed the image. It's present in the old first aid. And if we do our our X-ray, we are going to see some classic findings. The barrel chest, you will see the chest will be looking around and increased in size. The anterior posterior diameter of the chest will be increased. That is, that makes sense because of the increase in the capacity of the lungs. And you can appreciate that when you are looking at the lateral X-ray. I think you have an image. Okay, we have an image. Ah, where's the image?
Is an X-ray down.
Okay, yes. So this is the anterior posterior diameter. You can see it's looking like dome, barrel shaped, and the anterior posterior diameter increases. Then what else happened? We can also see flattening of diaphragm. So that flattening of diaphragm is actually due to hyperinflation of the lungs. So when the lungs are hyperinflated, they can compress downwards on the diaphragm and they make it flattened. That is it. It's the most sensitive sign on X-ray for emphysema. So there's increase in anterior posterior diameter, there's flattening of the diaphragm, and there's increased lung fluid lucency. Because hyperlucency means you have high oxygen content within that lung. That is it. High air, not oxygen. Air is within that lung. And if there is hyperinflation and too much air is retained within the lung, you are going to have hyperlucency. So those are the classic features that you are looking at for in your emphysema. We've talked about the way it happens. We've talked about the other parameters. So in addition to all these chest X-ray finding, if you do the diffusing capacity for carbon monoxide, it will be low. It will be low because of the fact that it's also affecting the respiratory membrane. So once it's damage the alveoli elastic fibers, damage the alveoli wall as well as the capillary membrane surrounding the alveoli, you cannot have diffusion of gases again. So how will this person present? Wow. So there's something that was omitted. Now, these guys, we've talked about them being the pink puffers. So they try to compensate for that problem. So what do they do? What they do is that they breathe with a pursed lip appearance. So that pursed lip appearance actually increases the airway pressure. So that at the end of the day, you don't have, because we've mentioned it initially that when there's a loss of that recoil, you cannot push air out to open the airway, because it is a recoil that helps to open the proximal airway that is just above the alveoli. So that means that they will kind of appear closed. That's the pattern of the obstruction. So if you do a pursed lip breathing, like you try to do your mouth as if you want to whistle, it will increase the pressure of air that you are taking into the lungs. So that will keep the airway opened. So that is why you don't typically see people that have emphysema being cyanotic. They are not typically that they even appear pink because of that mechanism. Okay. So we've talked about the mechanism, oxidative stress from smoking. Chronic inflammation is going to set in. You have the white blood cells being recruited, the T cells, the neutrophil, macrophage, they come around. There's a balance, there's an imbalance between protease and antiprotease. We've talked about it that the protease will be elevated from the neutrophils, which cause damage to the elastic fibers from the elastase activity from the neutrophil. So the elastase is the protease that damage the elastic fiber, leading to alveolar destruction at the end of the day. So that is the imbalance favoring increased protease. So the imbalance can also be due to reduced antiprotease. For example, someone that has alpha-1 antitrypsin deficiency. So there's no antiprotease to inhibit neutrophil elastase, which leads to unopposed elastase activity destroying the lungs. Okay, so let's go to the last one, the second to last rather, asthma. So asthma is an intermittent obstructive lung disease. So the symptoms are not always present, they appear episodically, and asthma is the only obstructive lung disease that the spirometry patterns actually reverse when you give bronchodilators. If you give the person albuterol now, it's going to reverse all these spirometry patterns that we are seeing. So it's more like an allergic condition that is associated with hyper 1 sensitivity, and it can be triggered by some things that we're already familiar with: allergen, dust mites, pollens, infection, viral infection, stress, and it's actually with atopy. So you can see other, allergic problems with it. So it's not uncommon for you to find someone with asthma having allergic dermatitis, eczema, allergic rhinitis. They are constantly scratching their nose and all those things. Sorry, before I go, you guys should remember the way they will present alpha-1 antitrypsin. So this person will be a very young person that has not smoked before. that is having liver issues and also having problems with the respiratory tract. The person is coughing, you know, productive cough, chest, tightened or chest pain, with dyspnea. So you know that this is likely to be a COPD with liver issue. And what you are looking at is alpha-1 antitrypsin deficiency. Okay. So, yeah. So, there's something. Okay. Now let's start with the mechanism for asthma. So the pathophysiologic mechanism for asthma is actually involving two things. There's the inflammatory component and there's the bronchoconstriction component. So the bronchoconstriction just happens due to the increased airway sensitivity. So people that genetically predisposed to developing asthma are naturally um, having high um, bronchial response. Sorry guys, I'll be with you guys in 1 minute. I'm coming. Yeah, so there's I hope you guys are still there. Can you guys still hear me?
Yes.
Okay.
Yeah.
So there's a bronchoconstriction. What I'm saying is high yield. You guys already understand what I'm saying. It's high yield. There's bronchoconstriction, and there's inflammation. So um the the inflammation can cause hyperstimulation of the airways, which will bring about hypertrophy of the smooth muscle, hyperplasia of the smooth muscles, one of those things that you see in them. And also there's bronchoconstriction. So they have some typical presentation: dyspnea, chest tightness, cough, wheezing. So once you see someone that is wheezing, you most likely want to consider asthma, and the episodes are usually intermittent and not constant, on and off. That is likely to be asthma. So in people that have asthma, we check their airway. The smooth muscles there, they are hypertrophied and they are hyperplastic. They are too big. So there's increased responsiveness of the airway. So any slight trigger, maybe just get exposed to infection or they get exposed to some pollen or dust mite, there's response of the airway and they constrict. So which brings about um the symptoms, which includes dyspnea, cough, wheezing, and tachypnea. And of course, from the inflammatory response that are there, we have interplay of the TFR cells, the TFR2 component. They come in, they release some cytokines, which stimulate the production of mucus from the goblet cells. So we have mucus plug into in people with asthma. So that inflammatory response and the bronchoconstriction together are responsible for the airway narrowing that you see in an asthmatic patient. Don't forget the bronchoconstriction and the inflammatory response. So the inflammatory response is from the type 1 hypersensitivity. So type 1 hypersensitivity, the cells that are predominant there include TFR2, which recruits eosinophils, as well as IgE immunoglobulins into that area from release of some interleukins, interleukin 4 and interleukin 5 predominantly, which start those inflammatory cascade and eventually bring about increased secretion of mucus with increased smooth muscle hypertrophy and hyperplasia that brings about the obstruction. So what are the other findings that you find in people with asthma? If you do like a lavage and you are able to bring out some of those mucus, we are going to see what we call Cushman spiral. So Cushman spiral is just talking about shedding of the epithelium into those mucus plug. I think we have an image for it. So these are the Cushman spirals, that shedding of the epithelial cells into the mucus. And this other one that we are seeing as a pointed sword, this is called the Charcot-Leydig crystals. So Charcot-Leydig crystal is just talking about the eosinophils that are present within the airway being broken down. So some eosinophilic proteins are broken down, because they get killed off and they are recycled, the new ones coming. So part of the product that they release includes the Charcot-Leydig crystal. So if you see them, they are pointing towards someone with asthma. And there's another thing that we need to know before we move from asthma. And what is this? The fact that it can be exacerbated. We can have a type that is exacerbated by use of NSAID or aspirin, We call that Samsters triad. So people that have asthma that is exacerbated by aspirin, they they have some additional things. Number one, they can have a nasal polyp, and so it's three things: asthma itself, nasal polyp, and NSAID, sensitivity, worsening the asthma. So how does this happen? How does this happen? So this happen because if you are giving someone NSAID, you are inhibiting the cyclooxygenase pathway, because NSAID or aspirin are cyclooxygenase inhibitor. You are activating the leukotriene pathway. So leukotriene pathway works by the lipooxygenase, not the cyclooxygenase. So the lipooxygenase activity are increased, which brings about production of leukotriene. Leukotriene is also one of those inflammatory mediators that drive the allergic process in asthma. Leukotriene. That's why one of the modalities of treatment is by giving leukotriene antagonist. So leukotriene causes bronchoconstriction. So we are now finding someone that asthma symptoms is exacerbated by use of NSAID or aspirin. I check their nose, we are seeing nasal polyp. That's likely to be Samson's triad. We should not forget that the spirometric pattern of asthma can be diagnosed when you have reversal of the symptoms with the use of bronchodilator. So there's a reversible obstructive pattern with a bronchodilator like albuterol, beta-2 agonist, or you can induce that narrowing by giving methacholine. So what you just do with the methacholine challenge, which is a muscarinic agonist, is by giving the methacholine, then doing spirometry. So you just notice that the dose at which you are going to achieve that spirometric pattern that indicate obstruction in someone that have asthma is going to be very small compared to the normal population. So there's a dose, but I don't think we should worry about the dose. I can't really remember it now. So that's all about the methacholine challenge test. The dose of methacholine that is going to bring about the obstructive pattern is going to be smaller than that of the normal individual. Okay, so bronchiectasis. Bronchiectasis is the last form of the obstructive lung disease. I want us to know that bronchiectasis is very, very associated with someone that has cystic fibrosis, not only cystic fibrosis, please, and someone that has asthma. Those two things, very common. Bronchiectasis, cystic fibrosis, and asthma. Now, bronchiectasis as a word just means dilatation of the larger airways. That's what it means. There's dilatation and destruction of the larger airways with thickening of the walls of these airways. It's usually more like a complication of the other diseases, like someone that has cystic fibrosis, someone that has asthma. Now, how does it happen? What are the causes? Let's start with the causes. Anything that can cause airway obstruction. Maybe you have a lung mass from a malignancy or foreign body aspiration. So that means that mucus cannot go up, along the airways to be expectorated in the esophagus and cleared or swallowed into the stomach. They'll keep accumulating within lungs, and at the end of the day, they will cause airway obstruction. So when there's obstruction with accumulation of that mucus plug, the mucus plug serves as a needle for infection to come in. So infection comes in, you have inflammatory mediators that comes around, release cytokines and everything that destroys those airway. So at the end of the day, they are destroyed, and particularly the larger airways, they become dilated. So once you are seeing dilatation of the larger airways, that is bronchiectasis due to problem with the extravasation of mucus. So what other things can also cause problem with mucus clearance? Someone that has poor ciliary motility, particularly people with smoking, like we've talked about, people that smoke, there is poor ciliary clearance, or people with Cartagena syndrome. Cartagena syndrome is a form of primary ciliary dyskinesia, so they cannot clear up the mucus. Mucus accumulates, infection sets in, um, chronic inflammatory cells are incorporated into the whole system, they destroy that lung. That is why if you look at some tests, they will tell you that the pathophysiology of bronchitis is actually the vicious cycle. So you cannot move mucus, infection sets in, chronic inflammatory cells also come around, they destroy everything. That destroyed airway, that area now also has problem with moving mucus again. Mucus keep accumulating, the whole process starts all over until they keep damaging the lungs. So that's all about Cartagena and tobacco smoking. The ciliary This motility also explains the pathophysiology of cystic fibrosis causing bronchiectasis. In addition to that, the mucus also accumulate. In people that have cystic fibrosis, mucus accumulate everywhere. They cannot move mucus because the mucus is apparently very sticky. So, and of course, the ciliary action too is impaired. So that's why you see them coughing out insipid mucus plug in cystic fibrosis. That's one of the salient points. They cough out, insipid or steeped, mucus plug. Allergic bronchopulmonary aspergillosis is also a cause of bronchiectasis. So allergic bronchopulmonary aspergillosis is very common in people that have cystic fibrosis. Like I'm sure Dr. Babande will have mentioned it in our BCH. Has he mentioned allergic ABPA? Has he mentioned it? Allergic bronchopulmonary aspergillosis when he was talking about cystic fibrosis. Did he? Hello, guys.
I don't think so.
Yes, he did. Yes,
Okay.
it is. Dr. Olushola is there.
Yeah. So it's very common in people with cystic fibrosis. Um. So, and it can also occur in other conditions like asthma too. But the problem there is just that the airway, they are very, very sensitive to this fungal spore. So the fungal that is causing this is Aspergillus fumigatus. So once they inhale the spores, they are hypersensitive to that. So they recruit the inflammatory cells, into that your T helper cell, your T killer cell, they come around and they start initiating the destructive cascade that brings about impaired, ciliary motility. So everything just boils down to this impaired ciliary motility from different mechanisms. Some are primary, some are secondary. The primary one is smoking and cartagena. They go there, they damage um that cilia directly. That's it. But in cystic fibrosis, you still have to have mucus accumulating. In allergic bronchopulmonary aspergillosis too, from the inflammatory cells, they stimulate the goblet cell, they produce mucus, they cause the obstruction. Just like people with tuberculosis too. The Mycobacterium avium or even the normal Mycobacterium tuberculosis, both of them can bring about hyperplasia of the goblet cells that bring about mucus that impairs ciliary activity that brings about bronchiectasis. So bronchiectasis can complicate so many disorders. So what are the ways by which they can present? So bronchiectasis number one, they have this chronic cough. They are coughing chronically. It's a chronic disease. Then number two, they produce a very foul smelling sputum, which is typically brownish, especially in people with allergic bronchopulmonary aspergillosis. I've not mentioned some things there. They produce brownish sputum, and because of the fact that I've talked about the fact that they can complicate people with asthma. So you just notice that this person is having fever with sputum production and is not responsive to antibiotics. That person has most likely had allergic bronchopulmonary aspergillosis. So people with bronchiectasis too can have all those things. Foul smelling sputum, fever, cough, and they can have some um, um, recurrent pulmonary infection. Then on examination, you notice finger clubbing. So finger clubbing is one of those things that you can see in people with chronic lung disease like bronchiectasis. Finger clubbing, very common in them. Finger clubbing. And of course, we've talked about the mucus occluding everywhere, so they can have recurrent pulmonary infection that further damages the airway, which brings about dilatation of the large airways. And they are permanent. They are permanently dilated. It's a permanent process. But the obstruction is actually happening due to the mucus accumulating within the proximal airways, obstructing them. So the proximal airways are actually occluded, but the larger ones which are more distal are the larger ones which are more proximal are dilated, while the smaller airways are occluded. So the smaller airways are occluded in bronchiectasis, the larger airways are dilated. We should not forget that because that's what we see for us to make diagnosis of bronchiectasis, dilation of the proximal airways. Okay, so what do you see on your imaging? Airway dilatation and bronchial thickening. And of course, if you do your spirometry, you see the obstructive pattern. That's it. From the history, you will have known that this is bronchiectasis. When they say chronic cough and they produce foul-smelling, purulent sputum, with recurrent pulmonary infection, finger clubbing, obstructive pattern, you know that this is bronchiectasis. So you just have to rule out the cause of that bronchiectasis. Yeah, so I think that is that about bronchiectasis. So Should we continue with restrictive lung disease or we should just continue from here tomorrow? Restrictive lung disease. Just like we've talked about, restrictive lung disease means you are having reduction in all the volumes. The residual volume, the functional residual capacity, and total lung capacity. If you do your pulmonary function test spirometry, the FEV1 is less than 80, the FVC is less than 80. But if you do the ratio, it is more than 70, or it can be normal. Now, what are the types of restrictive lung disease? Number one, the first one the problem with restrictive lung is that you cannot take it here. Now, two mechanisms. Number one, the first one is actually with altered respiratory mechanism or mechanics, anything that can impair the ability of the chest wall to take in air. Either you have paralysis of the respiratory muscles from conditions like polio, myasthenia gravis, Guillain-Barré, ALS. So you guys remember in ALS there's upper and lower motor paralysis. So the lower motor neuron lesion can cause respiratory muscle weakness that can, bring about problems with taking in air. Guillain-Barré, we talked about it. So Guillain-Barré syndrome can cause respiratory paralysis, and at that time, when it's already affecting the diaphragm, you want to mechanically ventilate that guy, and it's a bad sign. Myasthenia gravis, we know that polio, very easy. Chest wall abnormality, so there's no problem with the respiratory muscle now, it's the chest wall. Is it that the shape is abnormal? Someone has kyphoscoliosis. So from kyphoscoliosis, there's abnormal curvature of the spine and the chest wall anteriorly. So the chest wall is not able to, expand and fill in with air accordingly, because that capacity of the chest wall, capacity of the chest wall has been reduced. Because if the chest wall is not, if it's curved, it tends to accommodate less lung expansion and volume compared to if it's wide. So in kyphoscoliosis, that curvature impairs, the expansion, and also people with severe obesity, because you have fat occupying the entire chest wall, so that expansile ability of the chest wall cannot happen. So it's limited in people that are severely obese. So that is the obesity hypoventilation syndrome that we are talking about. Chest wall abnormality, kyphoscoliosis, and obesity. Respiratory muscle weakness, polio, myasthenia gravis, ALS, and the other ones. Now, these ones are extrapulmonary. They are not problem with the lungs itself. It's the muscle and the chest wall. They are going to have a normal diffusing capacity for carbon monoxide, because of the fact that it's not affecting diffusion of carbon monoxide across the respiratory membrane. If you give carbon monoxide, it will still diffuse across the membrane. There's no problem with it. And the A gradient will be normal. They will have hypoxia, but the A gradient will be normal because it's affecting both the alveolar partial pressure as well as the arterial partial pressure, like you guys have talked about. We've talked about it. A gradient is normal. So if you see someone having a restrictive lung disease pattern, they've given us FEV, FVC ratio that is more than 70%. They told us FEV1 is less than 80. You know that is restrictive they are talking about. FEV1 is less than 80. FEV1 ratio over FVC is more than 70. Residual volume is lower than normal. They now said that this person is having myasthenia gravis. They start painting myasthenia gravis. Difficulty, in seeing, blurry vision, diplopia, different difficulty moving, myasthenia gravis. They can ask us, what would be the A gradient in that person? It will be normal. What would be the diffusion capacity for carbon monoxide? It will be normal. Or they can even give us all those parameters and give us A gradient that is normal. They now tell us, among all these causes, which one is the cause of the respiratory lung disease? We'll not go and pick sarcoidosis. We'll not go and pick Wegener's. We'll pick maybe Guillain-Barré or ALS. So, if it's not affecting the respiratory muscles or the respiratory mechanisms itself, like the chest wall and the respiratory muscle, can it affect the lung itself? So, when there's affectation of the lung itself, that is what we call interstitial lung disease. So, interstitial lung disease is actually a general term. It's an umbrella term for so many problems. It is strictly pulmonary. It is affecting the lung parenchyma itself. And because of the fact that the alveoli is part of the lung, they cannot diffuse carbon monoxide. So the diffusion capacity for carbon monoxide is reduced in there. And of course, there will be problem with taking in air, oxygen, from the alveoli into the blood. So the A gradient is possibly enlarged in them because it will not affect the alveoli grade concentration, just like we have in respiratory mechanism problem. This is lung problem. The person can hyperventilate and maintain the alveolar pressure. It's not affected. It's not affected. But the getting oxygen into the pulmonary capillary is affected. So A is low, but the big A is normal. So at the end of the day, A gradient is what? Increased. So what are the causes? Pneumoconiosis, occupational lung disease, like people that are exposed to coal, people that are exposed to silicon, especially miners, or people that work in asbestos industry or aircraft, asbestosis. Okay, aircraft will be beryllium. So asbestosis like people that work in all this pipe, roofing, material shipping, and all those things, asbestosis. Yeah, sarcoidosis too can be a cause because sarcoidosis affects the lung parenchyma itself. There's granuloma everywhere. So we'll talk about sarcoidosis, a chronic inflammatory disease of the lung. So you see non-sedating granulomas because it's not infectious, so it will not be sedating. And it is one of the commonest causes of bilateral hilar lymphadenopathy. Once you guys are seeing bilateral hilar lymphadenopathy in the question, oh my God, sarcoidosis should be the first thing in your mind. They're not telling you the ACE enzyme is elevated, calcium is elevated. Calcium will be elevated because sarcoidosis is one of the causes of increased alpha-1 hydroxylase activity. So that alpha-1 hydroxylase activity will make, from the macrophages, will make vitamin D, which is vitamin D production to be increased. So which is conversion of the 25 hydroxyl cholecalciferol to 125 hydroxyl cholecalciferol, which is vitamin D. Vitamin D causes reabsorption of calcium. That's why calcium is elevated. And ACE enzyme is also elevated in people with sarcoidosis. There are other things we'll talk about it when we get there. Idiopathic pulmonary fibrosis is a cause of respiratory lung disease. We'll talk about it. Wegener's affect the lungs. It's a vascularity that affects the lungs, so it can also affect the parenchyma. The condition like pulmonary Langerhans cell lymphocytosis, they cause hypersensitivity pneumonitis, they cause drug toxicity like bleomycin, busulfan, amiodarone, methotrexate. This drug can cause pulmonary fibrosis that is not idiopathic. So these ones are actually the ones that cause it, so it's not idiopathic. Pulmonary fibrosis can be a cause. Acute respiratory distress syndrome is also a cause of restrictive lung disease because it affects the lung parenchyma. Radiation induced lung injury. So this is also something. People that are exposed to radiation, maybe for treatment of cancer, the radiation, can generate free radicals. There's a rate of inflammatory cytokines, particularly TNF alpha, interleukin 1 and 6. These ones cause damage to the endothelial cells. There's extravasation of fluid into the lung parenchyma. At the end of the day, there's edema. There's damage to the epithelial cells of the airway and the lungs itself. And they start presenting with fever and dyspnea with cough that is dry. The cough is not productive, it's dry. They can have dyspnea and with or without fever. So this phase is actually called the acute radiation pneumonitis. So this is the inflammatory phase. It is, the acute inflammatory cells that is causing majority of these symptoms. They can have cough, dyspnea, and low-grade fever. Sometimes it might manifest with this symptom, but most of the time they are asymptomatic. After some time, after about 6 to 12 months, your chronic inflammatory cells comes in, the macrophages, the fibroblasts, they start depositing transforming beta growth factor, as well as your type 2 pneumocide. They start trying to repair. So there's deposition of collagen, which brings about fibrosis of the lung. So these guys will actually present with, symptoms of pulmonary fibrosis at this point. So the acute inflammatory response, which brings about the acute radiation pneumonitis, occurs within 3 to 12 weeks. That's 1 month to about 3 months. Then from 6 to 12 months, if that radiation is still being continually exposed, it can cause fibrosis. So we'll talk about pulmonary fibrosis proper. We'll know the way they present. So idiopathic pulmonary fibrosis. So forget the fact that it's idiopathic. Idiopathic pulmonary fibrosis or normal pulmonary fibrosis that is not idiopathic is the same thing that they will present with. This is just talking about progressive fibrosis of the lung disease, but you don't know the exact etiology. So you just have that repeated cycle of lung injury happening. Inflammation is just setting in, and at the end of the inflammation, you want to repair the damage that the inflammation has caused, which will bring about eventual fibrosis. So it's as the risk factors for idiopathic pulmonary fibrosis include people that smoke, people that have some genetic problems, or people that are exposed to some environmental pollutant like some dust, maybe like stone dust, silica, you know, so many of those dust, that wood dust, you know, from factories. They're exposed to all those things. This has been shared with idiopathic pulmonary fibrosis. So, how would they present? How would they present? They have this slowly progressive dyspnea. So the dyspnea is not acute. It's just they will tell you that it progresses over the month, and of course they are going to have the cough. Then I've mentioned crackles. Mm. Crackles is also one of those things that you find in pulmonary fibrosis. So the inflammatory process causing the repair, with eventual fibrosis of the lung parenchyma brings about the crackles. And because it's a chronic disease, there's finger clubbing too. Finger clubbing, happens. So the dyspnea brings about the fatigue that they experience at the end of the day. Just imagine someone being dyspneic for a long time. Person become fatigued at the end. But what I want you guys to pay attention that is high yield here is that you have um some imaging findings. What are these imaging findings? Number one, peripheral reticular opacity. You are going to see opacity on the lungs on your X-ray that looks like net-like. So once you see the word reticular opacity, please pay attention to that statement. It's likely to be pulmonary fibrosis. You are likely to deal with an interstitial lung disease. Peripheral reticular opacity, and that opacity is actually due to traction bronchitis, bronchitis rather. So what that means is that when you have fibrosis from the chronic inflammatory response, those fibrotic airways or parenchyma are going to pull down on the other ones that are normal, that are superior to it. So gravity is going to help them. They'll pull them down. That's the traction from their weight. They'll pull the proximal airways down, and they are going to dilate them. So you are going to be seeing dilatation of the airway, and you are not seeing any features of bronchiectasis. Maybe anything that can cause bronchiectasis in that person, and you are seeing evidence of bronchiectasis. That is, of course, the person will not be producing sputum. The person will not be producing foul-smelling sputum, and is having dilatation of the airway. That's likely to be a traction bronchiectasis from pulmonary fibrosis due to the downward pulling of those fibrotic areas. So it is that downward pulling that is causing this reticular opacity. So it's going to be net-like, and you tend to see it at the basal aspect of the lungs. And because of the fact that you can have patchy, fibrosis in the area, those fibrotic areas are going to create cystic spaces within the parenchyma. So that's what brings about the honeycomb appearance of the lung, parenchyma. You tend to see that in advanced case of pulmonary fibrosis. Cystic spaces that are more than like 3 millimeters, surrounding fibrotic areas. That is what represents the honeycomb appearance of the lung. You can see it on the X-ray, you can see it with your CT scan. And if you do a biopsy, it's very similar to what you find with interstitial pneumonia. You are going to see that patchy fibrosis, in your interstitial pneumonia. You tend to have reduction in the type 1 pneumocyte. Of course, they will have been destroyed, but there's an increased production of your type 2. You guys remember that type 2 pneumocytes, they are progenitor cells, and they help to produce
Mm-hmm.
surfactants, and they also help to mediate tissue repair. So, of course, you are going to
Type
have
1.
increased
Yeah.
production of your type 2 pneumocytes. So, type 2 are going to come around to repair those damage. At the end of the day, you have recruitment of fibroblasts that will lay down those connective tissue that bring about the fibrosis. So this one we should be able to answer this. What will be the cell picture in someone that has pulmonary fibrosis? Type 1 is going to be dead because they are the ones that form the squamous cell epithelium. They are going to be damaged. And the type 2 is going to be produced so that they can bring about the repair. And I really want to lay down fibrosis that brings about the fibrosis at the end of the day, the fibroblasts rather. So what are the complications? Because of the fibrosis, there's going to be hypoxemia. Hypoxia happens reduce delivery to the hair, to the lungs, reduce air delivery to the lungs, and of course to the pulmonary capillaries at the end of the day. That brings about vasoconstriction, which can explain the pulmonary hypertension that they have. When they have pulmonary hypertension, the afterload on the right side increases. They have right pulmonary hypertrophy. When they have right pulmonary hypertrophy, they can have a coronary heart disease from there because demand is going to be more than supply. When there's right pulmonary hypertrophy, when there's right ventricular hypertrophy, demand of that heart is more than what it's likely going to be supplied. So there's a need for increase in the supply. When the need for increase in the supply cannot go or cannot commensurate with the demand, you tend to develop a coronary arterial disease or ischemic disease. And of course, the right ventricular hypertrophy is a needle for arrhythmia. Arrhythmia is going to set in. They can have right ventricular failure if everything fails at the end of the day. The right ventricle hypertrophy cannot, bring increased delivery of blood into the pulmonary circulation. It fail, backflow of blood into the extremities. They can have respiratory failure, reduced oxygenation and likes. And pulmonary fibrosis, because it's a chronic inflammatory process, it can eventually lead to a lung malignancy. Yeah. So that is that about idiopathic pulmonary fibrosis. I don't want you guys to forget.
Sorry, can you okay, continue.
Can I what?
Continue what you are saying.
Hypersensitivity pneumonitis. Hypersensitivity pneumonitis is actually a type 3 and a type 4 hypersensitivity problem. So it's a mixture of both type 3 and type 4. That is it. You tend to see it in farmers, that are working on the farm, or farmers that are handling bird. We call them bird fanciers. So they can be exposed to some environmental antigens like thermophilic actinomyces as well as aspergillus or droppings from the bird. So when they inhale them, there's a hypersensitivity response. So the hypersensitivity can be type 3 or type 4 and it can coexist. So type 3 meaning that you have these antigens, the droppings from the bird, the antigens of the aspergillus and the actinomyces in these farmers, stimulating production of antibodies. So these antibodies and the antigen complex deposit within the lungs that brings about recruitment of our T lymphocytes, which orchestrate that damage, that inflammatory response that they experience. So it starts acutely. They will just, acute inflammation, the lymphocytes are just coming in, the neutrophils are also there. They are causing the lung damage. They can experience, because of that is an hypersensitivity response, so they can experience symptoms like, dyspnea, cough, chest tightness, fever. These are non-specific symptoms. And you can have that alteration in the halting of that process if you remove the stimulus. But if the stimulus is still being continually exposed, if they have continuous exposure to the stimulus, it can progress to a chronic form in which you now have the CD8 now coming in, the macrophages coming in, causing fibrosis, just like we've talked about. So fibrosis, your macrophage, your CD8 activate your type 2 pneumocite, which brings about the fibrosis. And of course, because the CD4 cells are involved, the macrophages are involved, they can form a non-circulating granuloma around that antigen. Because at the end of the day, they cannot degrade those antigens. They will still be there. So at the end of the day, they will just form a granuloma around that antigen. So the antigen will be central, the macrophages will be next to them, engulfing those antigen, and of course, we are going to have the CD8 cells, the CD4 cells outermost. So because of the fact that they can cause irreversible fibrosis, it can bring about the traction bronchiectasis that we have talked about. Anything that causes fibrosis will bring about bronchiectasis. So my point about hypersensitivity pneumonitis is just you having a trigger for that inflammatory response to be antigens such as the thermophilic actinomyces and aspergillus that I can see in farms, or farmers that are handling the bird droppings. So the type 3 hypersensitivity comes in which you have antibodies being produced against those antigens. They deposit within the lungs, they recruit the chronic inflammatory cells, and the type 4 hypersensitivity, which means CD8 or CD4 cells are strictly what is produced against those antigens. So they orchestrate all those chronic inflammatory response that brings about fibrosis and eventually granuloma, which brings about the traction bronchitis. So that's all about hypersensitivity pneumonitis.
So, Dr. Babarade, unlike asthma, this one is CD8 and
CD4 too is
um
implicated.
CD4. Okay,
Yeah,
at the initial stages, Abi.
at the initial stages, exactly. So with
Do we
time,
see IgE?
uh, you will not see IgE. Why? IgE will be seen in type 1. So IgE is for type 1. So in asthma, you see IgE. Mm. Here, you will not
So
see
this one is
IgE.
type 4, right?
This is type 3 and type 4. Type 3 and type
This
4.
so 3 first, then 4. Okay,
Yes, yes.
okay.
So,
Thank you.
exactly. So, that is that. So, Dr. Lushala, do you have any question you want to ask me now?
I was just wondering why I didn't get what you said that the type 1 and type 2 pneumocytes were doing again.
Okay. The type 1 pneumocyte, they are the squamous cells. They form the squamous cells that line the alveoli that facilitate gas exchange. That's what they do. But in someone that has a pulmonary fibrosis, they will have damaged those epithelial cells of the lungs. So type 1 pneumocyte will have been, removed. They will have been damaged. That's why they are reduced. But type 2 will not go because type 2 pneumocyte, number one, they contain progenitor cells that can produce more type 1 and more type 2. And they also help in tissue repair when there is a damage. So they have to be increased so that they can repair that damage that is ongoing. And you know that
Okay.
it's an inflammatory process. One of those cells that will be recruited will be fibroblasts at the end of the day. So it's a chronic inflammatory process. So fibroblasts will come in, they will lay down the collagen, that brings about the fibrosis at the end of the day. Do you guys get it? So majority of all these things will become very clear to us by the time we are looking at questions. So okay.